before we begin, would you please all make sure your phones are on silent or whatever works best for you all? Oh, it helps, huh? Okay. Just, okay. Okay. Good morning, everyone. Welcome to our Black History Month presentation. My name is Dawn Walker. I am Vice President of Communications and Marketing here at Downstate. I'm honored to welcome you all on behalf of the Office of the President and President Riley, who extends his wishes for a successful and thought-provoking discussion. At Downstate, we're proud to be part of a community that values diversity, equity, and inclusion, and we're proud to know that we are committed to making sure that we continue along those paths. Black History Month is a time to honor the pioneers who have paved the way, celebrate the leaders who continue to make a difference, and to recognize the resilience and contributions of Black communities, not just locally, but globally. It's also a moment for us at Downstate to reflect and reaffirm our commitment to equity in healthcare, research, and education. Today's panel, Advancing Health Equity and Uncertainty, Challenges, Progress, and the Path Forward, brings together eminent voices to explore the evolving healthcare landscape and its impact on Black communities. Our panelists will examine the progress in addressing health disparities, the persistent challenges, and the strategies needed to create a more just and equitable healthcare system in a rapidly changing political landscape. I'd like to extend a special thank you to our esteemed Downstate panelists, Dr. Daniel Elke, Dr. Marilyn Frazier, Dr. Brian McNeil, and Dr. Azura Thompson, to our special guest panelists, Brooklyn Deputy Borough President Reverend Kimberly Council, and a special thank you to our moderators, Dr. Marcus Lambert and Dr. Teresa Smith, for sharing their insights and leading this important and timely discussion. Whether you're joining us in person or virtually, your presence and engagement makes discussions like these significant and meaningful. At Downstate, Black history is not confined to a single month. It is interwoven into our institution's past, present, and future. We continue advancing equity, representation, and progress in medicine and more through programs like this. I'd like to take a moment to welcome Dr. Morris Salafu, Chair of the Department of Medicine and Director of the Kidney Transplant Program. He is also a Director of the Brooklyn Health Disparities Center. Dr. Salafu has dedicated his career to advancing health equity, improving patient outcomes, and mentoring the next generation of healthcare professionals. His work in health disparities, organ transplantation, and chronic disease prevention has made a profound impact on underserved communities, particularly here in Brooklyn. Dr. Salafu, we look forward to your words of wisdom. Please join me in welcoming Dr. Salafu.
Thank you.
Thank you very much, Dawn. I also join you in welcoming all of you to this very important Black History Month. We have an incredible panel. The title is really very catchy. Advancing Health Equity and Amid Uncertainty, Challenges, Progress, and the Path Forward. So this is very timely. My name is Dr. Morris Salifu. I have been very much involved in the Health Disparities Center for the last 20 plus years. We've done a lot of work in the community with a lot of partners, including the Ash Institute for Urban Health, and have really moved the needle with the main goal of reducing health disparities and health inequities in Brooklyn overall. That's the mission. I have the privilege of working alongside with several of the colleagues today along that path to confront the challenges of health inequities head on. Our mission has always been clear: to ensure that every individual, regardless of the background, socioeconomic status, has access to high quality healthcare and has the resources and opportunities to a healthier future. So this event is crucial to provide a platform for dialogue, collaboration, and action. It's very challenging given the political circumstances right now, but we cannot sit back and just keep quiet. We have to keep moving forward. The issues we tackle are not abstract, but deeply personal to our communities. And again, we cannot sit back and not address the community issues and plan forward. And we do this because we're an academic medical center. We do this through research, education, and direct community engagement. As a matter of fact, in the last 10 years or so, the activities of the Brooklyn Health Disparity Center has attracted so many millions of dollars to this institution just to do exactly that. So we are not really passive on the subject. We're really very active on the research aspects. Unless you do the research that addresses some of the questions and then highlights what can be done to resolve them, you really are really walking the dark. The work, even though we want to go into the community and make change, but we also always have to remember that the research is so crucial to identifying the root causes of these problems and also engaging the education of the next generation of people who would be interested in the subject and then advancing the field as well. So I really am very lucky to have so many people who have done this work, including Dr. Marcus Lambert. You can go to the website. It's called Transport, like Transport Program. If you go to Downstate website, you type transport, you're going to see a lot of activities around transport. We're educating students from high school all the way to postdoctoral students to understand what we're going to be discussing today so that they will be part of that conversation in the future. And they will be the change agents in the community and the transformation of the community so that we can all have an equitable access to healthcare. So today's discussion, we are very fortunate to have outstanding moderators whose expertise and leadership will guide us through these critical conversations. First is Dr. Marcus Lambert to my right. He is Associate Vice President for Research Strategy and Operations and Associate Professor in the Department of Epidemiology and Biostatistics. So that is a very long title. He's a recognized leader in research strategy, dedicated to advancing scientific innovation and promoting equity in health research. Dr. Lambert is just an amazing person. He came to us from Cornell with incredible health disparities portfolio, and he's really very passionate and deep about the subject. And I work with him on a day-to-day basis. The second moderator is Dr. Teresa Smith. She's to my right, to the extreme end. She is the interim chair of the emergency department. She's also a professor of clinical emergency medicine and associate dean of GME, graduate medical education. So we truly have a powerhouse to moderate the session for us. Dr. Smith is an accomplished clinician, educator, and mentor to a lot of students and residents and junior faculty members. As a matter of fact, when she was the DIO, the designated institutional official for our institution, in those 3 to 4 years, we saw some amazing things that happened to our residency programs, and we're just so lucky to have her in this institution. She is committed to training the next generation of healthcare professionals as well, and also advancing health equity, especially advancing emergency medicine equity. So Dr. Lambert and Dr. Smith will help shape today's dialogue, ensuring our discussions remain insightful, impactful, and solution-driven. So thank you for being here. I look forward to an engaging and meaningful conversation, and then we can take home some points and make use of them. So thank you.
Thank you, Dr. Salafu, for that warm welcome. Before we begin, I really also want to give regards from the Office of the Senior Vice President for Research, Dr. David Christini. He sends his regards as he's away for a conference, but he really wishes that he could be here. Now, we'd like to, my co-moderator and I, introduce our panelists. Let's get started with the person to my right, Dr. Dan Elke. Dr. Elke is an associate professor of health policy and management at the SUNY Downstate School of Public Health, where he examines health system design and political forces driving reform. His research spans the U.S. healthcare landscape, including the impact of the Affordable Care Act and global systems, with particular focus on the British National Health Service. A central theme of his work is the tension between healthcare as a fundamental right and the increasing role of medical consumerism. Next to Dr. Elke is Dr. Marilyn Fraser. She's the Chief Executive Officer of the Arthur Ashe Institute for Urban Health, a research professor in the Department of Medicine and the School of Public Health here at Downstate, and one of the co-directors of the Brooklyn Health Disparities Center. Previously, as Deputy Director and Associate Director for Research and Training, she managed the Arthur Ashes Institute's community outreach and research programs. She's a co-leader on several NIH and CDC grants, and Dr. Fraser has really helped to develop behavioral health intervention models and training curricula.
Then moving right along, we have my Morehouse brother, Dr. Brian McNeil, the Vice Chair of the Department of Urology, an Associate Professor of Urology at SUNY Downstate, where he works to improve patient outcomes and mentors the next generation of medical professionals. As a presidential leadership scholar and advocate for healthcare equity, Dr. McNeil is developing Urology 205, which is a comprehensive initiative to address urological disparities. This effort focuses on raising awareness in underserved communities, establishing national guidelines for improved care, and expanding the pipeline programs to attract underrepresented students to urology and surgical subspecialties. Dr. McNeil, after going to esteemed Morehouse College, obtained his doctorate of medical medicine degree from the University of Pittsburgh School of Medicine and an MBA from NYU Stern School of Business. And next to him, we have Dr. Azura Thompson, who's an assistant professor of community health sciences in the School of Public Health. Her areas of expertise are urban health, women's health, substance abuse, and mental health. Her research centers on social determinants of substance abuse and mental health, particularly among Black women in urban settings. Through this research, Dr. Thompson seeks to inform the development of programs and policies that contribute to eliminating addiction-related health disparities. Dr. Thompson received her doctorate PH and MPH in social medical sciences from Columbia University and a BA in journalism from Howard.
HU.
I know.
Okay.
You know. Okay.
Okay. We got Spellhouse and HU here. We'll acknowledge. We have our esteemed guests, the Reverend Kimberly Council. The Brooklyn Borough President, Antonio Reynoso, appointed Reverend Kimberly Council as Deputy of the Brooklyn Borough President in April 2023. She has built a distinguished record of community service, particularly in advancing public health initiatives. As Executive Director of the Barine Community and Family Health Life Center, she organized food pantries to combat food insecurity and developed youth enrichment and violence prevention programs to strengthen community well-being. As an executive board member of the Women of Faith Advocating Change, Reverend Council raises awareness of health disparities affecting women of color and contributes to health policy discussions through her work on the Advisory Council of the Dreyfus Health Policy and Research Center. Her public health leadership includes organizing wellness fairs for seniors that provide fraud prevention education and health screenings. She also led efforts to establish a preventive care clinic in a healthcare desert, ensuring essential services for underserved populations. And acknowledge my boss, the Dr. Charles Brudicardi, who's here. And I also just want to acknowledge his continued support in the academics and always making sure that we include diversity, equity, and inclusion in everything that we do in our medical education mission.
So let's get started. I want to start our conversation really talking about health disparities and chronic disease. Chronic disease, particularly heart disease, stroke, diabetes, cancer, continue to be leading causes of death, and particularly premature death in New York City. I want to give a couple facts for our audience before we get into the question. First, in 2021, chronic disease caused more than 40% of premature deaths, and more than 30,000 New Yorkers of any age died from these conditions. Number two, some parts of the city, such as North and Central Brooklyn, have a higher premature death rate compared to the other citywide average. And the third thing I want to leave our audience with is that non-Latino Black New Yorkers have experienced higher rates of premature death, 3 times the rate of other groups such as Asian or Pacific Islander New Yorkers. So with these sort of facts in mind, this question could be answered from anyone on our panel. How do you begin to explain some of these persistent health disparities that are affecting especially predominantly Black communities today? What are the root causes of these disparities?
maybe I'll get started with that one. First of all, I'm honored to be here with all of you and my fellow distinguished co-panelists. Just as the Black community itself is extremely diverse, there is no single one-size-fits-all diagnosis, nor one-size-fits-all solution, I think, to these problems. We, of course, have to go all the way back to the very beginning of our historical experience. We can't but talk about the tradition of the mechanisms of oppression, the institutions of oppression that go all the way back to slavery in the United States, but continued for far too long with Jim Crow and continued institutional racism. So that is a part, certainly, of the explanation. But when we talk about these inequities that you've mentioned, we also need to touch on a concept known as the social determinants of health. These are the so-called kind of upstream factors that fall outside of our healthcare system, but nonetheless have a key role when it comes to determining well-being. So these encompass issues like housing insecurity, food insecurity, inequities when it comes to education, inequities when it comes to the quality of basic infrastructure and the density of social networks. All of these come together to form something of an unholy stew, if you will, to create and really to continue to perpetuate the inequities that we see with many of these chronic conditions. You add to that, over time, the erosion of the tax base in many urban communities particularly, and the neglect of what were all too often largely white male political establishments that simply ignored the needs of Black communities. So I think all of that together starts to bring us down this road to beginning to explain these deep and ever seemingly perpetual inequities that we see. Of course, there are many other dimensions, and my co-panelists, I'm sure, can continue to fill that in.
Yeah, I agree with you. There's so many systemic changes, so systemic things that we need to address when we talk about the inequities that happen, right? And when we talk about thank you. When we talk about healthcare, we talk about health inequities, and we see so many things happening. And I think even going further, these systems are intentional and they happen. And even when we think about our own communities, how they're created and how they're mapped and how they're put together, these things are intentional that so that we will have health disparities. The system is working the way it's set up to work, really. And so going even further, thinking about, yes, we know all the reasons, we know all the inequities that exist, we know all the intentionality that comes with it, we know about racism, we know about all of these different aspects, but then we have to think about, okay, what do we do? Right? And I know that's probably the other question, right? It's like, yes, we know this. We've done the research. We've seen what inequities do. We've seen what the causes are, but how do we address it? How do we change that system? How do we dismantle the things that are happening? And that comes with communities working together. It comes with academic institutions, community-based organizations. It comes with faculty. It comes with not being silent, as Dr. Salafu said. It comes with the choice of us being disruptors and deciding that we need to make a conscious effort to break down the systems, break down the barriers, going out into our communities, asking them what they need. What are the things that we can do to assist you along the way? And really being out there and voting. Right, and making those changes, not being satisfied with the status quo, but making those changes. So I think it is a complex system that we are in. We know all the different drivers. We know the different things that are contributing to it. So now it's like, okay, what do we do with that? And so I think that's where we need to move on to in terms of like, okay, how do we dismantle these systems?
I mean, I agree wholeheartedly with everything that has been said. And I do want to pause for a second and let you know that I went to North Carolina Central University. We got 3 HBCU grads on this panel. But as you were talking, I was thinking about the fact that it is very important that we go into the communities and talk to the people in the communities and find out what it is that they need. Because so often it's top down and not bottom up when we start to design the things that need to happen. But we also need to bear in mind that as we're going into these communities, there's a huge level of distrust, even with the medical community. Understanding that historically, Black bodies have been used as experiments. So you're coming against a group of people who have been under oppression for so long and have been systemically counted out for so long. And even when we have people that look like us in office, it doesn't seem to translate into us doing better. So there's a whole lot of work that has to happen in the ground, but we've got to restore trust before we can even get to the point where we can start talking about solutions.
I just like to add to think about this as a public health person, researcher, and coming into the field over 20 years ago, trying to answer this question. And so this is not, something that schools of public health, at least 30 years, if you think about the introduction to the concept of health disparities within public health, we have been trying to address this question for a long time. And it doesn't mean that these disparities have not existed for hundreds of years. And in fact, that's kind of what brought me to this field when I was at Howard University. Bison. And many of you New Yorkers may know about the African burial ground. And what you see in that burial ground are premature deaths, babies, at a higher number than other burial grounds from that period. And so it was that, exposure that like, okay, why is this persisting for hundreds of years? And it's really about these systems. It's really about the history of enslavement, Jim Crow, and all of the ways that these systems are maintained through our laws and policies and things like that. And in a way, I'm challenged by maybe the limits of public health to really address these root causes. So there's always a tension for me. Like, am I in the right space? Should I be in politics? Or should I be in some type of job creation or job promotion programs? Or should I be working more with unions? So when I think about the root causes, they're economic. The history of slavery is economic. What the conditions that we see people are living in are related to economics. The disinvestment of our hospitals and our communities is economic. So I always have this tension, like, am I in the right space? Or, I can make the contributions where I can, which may be like a little piece, but that's maybe just enough for me, so.
Thank you, thank you. And as it is Black History Month, I do want to acknowledge all of our esteemed HBCUs.
Now.
And to just say that Downstate is a magnet for the talent that our wonderful HBCUs have created. And so that should definitely be acknowledged, because there's many more HBCUs in the room, so I'm going to acknowledge them all. Okay, so let's talk about access to care. Many Black communities reside in medical deserts where hospitals and primary care facilities are scarce. Even in the areas where hospitals and primary care facilities do exist, years of disinvestment and underfunding have left facilities struggling in the community. There are even talks of lifetime Medicaid caps. Thinking about that, and there are many other policies that are being brought up in the last month or so. What policies or initiatives have effectively mitigated barriers to healthcare access in Brooklyn's Black and Brown communities?
Yeah, so I don't know how long ago, I know Faven or I is in this room as well, but maybe about 8 years ago, one of the things that we started doing, and just for people that may not know the Arthur Ashe Institute, it was founded by Arthur Ashe. He really wanted to, it was founded by Arthur Ashe 32 years ago, and he really wanted to address health inequities. And you think about 32 years ago, what the landscape looked like, and it's sad that at 32 years post that we're still having this discussion, we're still talking about those things. And so a lot of the things that we have done would be to go out into the communities and to address health disparities by going into beauty salons and barbershops and faith-based organizations. But about 8 years ago, we started working with other community-based organizations, and we developed this consortium called Communities Together for Health Equity. And that consortium is made up of about 70 community-based organizations across New York City, and they're focused on addressing social determinants of health. And these organizations serve to link people to care. So link people to all the issues that, Daniel, you listed in terms of social determinants of health, link those folks to those kinds of services. But also when we talk about trust and the mistrust, it's important to go to the community, right? So we've gone into beauty salons, as I mentioned, faith-based organizations, and also barbershops, and train barbers and stylists so that they could talk to their customers about health. And it is undoing some of the distrust that they feel, because, as you said, just because somebody looks like you doesn't mean that they have your best interests at heart. So that's one of the things that we have done, and we have trained people on a whole host of different things. But in training folks to talk about health, it's important that you have resources, that they know where they can go, where they can be linked to services, even something as simple as having questions that you should ask your doctor, because sometimes we go to the doctors and we don't know what to ask. And so those are some of the things that we are doing. Another piece of our access is to train the next generation of healthcare professionals, and making sure that from high school, middle school, that you're talking to people about health, talking to students about health, and helping them to see a path forward that they can also be part of the solution, where we talk about health disparities and we talk about health inequities. So those are just some of the things that we are doing in terms of access to health.
Thank you, Dr. Fraser, for all that you do to improve access to health. It's an inspiration, I think, to all of us. Zooming out from the local level too, you mentioned Medicaid in your question, and it is vitally important to make sure that we defend and stand up for Medicaid. Medicaid is endangered today in a way that has not been for many, many years. Medicaid started all the way back in 1965. I'm not going to go through the entire history, don't worry. My students' eyes are glazing over already, I can tell. Started all the way back in 1965 as really an afterthought to Medicare. It wasn't mentioned in the popular press for years after it was passed, but it has become a healthcare behemoth over time. Today, Medicaid, among the many other items it covers 49% of births in this country. It's a huge medical footprint. It has been an entitlement program, which means not only that it is entitled in law, but if you are eligible for the program, and today, thanks to the Affordable Care Act, many, many more people are, the money always flows. So the state always gets the money it needs from the feds to cover everyone who is eligible. That may be about to change. As you talked about, there are still very early stages underway that could turn this program into a per capita cap program. What that means is that the federal government would determine, okay, about how many people might need Medicaid in a given year, and then the state would receive the money in a lump sum. Once the money runs out, that's it. So if there were any unexpected downturn in the economy, communities suffered challenges that, perhaps were not planned or anticipated, the money may not be there. So that is the sort of fundamental transformation that we may be facing when it comes to Medicaid. Just last night, the House passed its budget resolution with an implied significant cut to Medicaid. Perhaps with the addition of work requirements as well, which would make it all more difficult for people to access the health system in the ways that they need to. So I also think that embracing and standing up for Medicaid, vitally important.
I think you should run for office. I mean, I think, not, I'm talking to you. Yes, I'm talking to you. No, so it's both and. There's so many different, entry points. And I mean, just thinking about the access to medical care, so in my community, in my church where I was born and raised, St. Mary's Hospital shuts down. All right, St. Mary's where I gave birth to my son. What did my church do? We had a doctor that was a member of our church. We started a medical clinic in what was the parsonage. We began a health ministry in our church. We began having conversations with the members about, developing relationships with your physicians. Because when I was growing up in Bed-Stuy, we would go to the clinics, and you would be there all day, and you felt like a number. And you kind of went in and went out. It felt like a factory. But as an adult, as we begin to have these conversations and begin to understand, like, you should have a relationship with your physician. It shouldn't just be something where you go in where you're having an issue. So having those conversations on the ground with the people, I think, are very important. But when you look at what is happening at the federal level, like, we have a bully in office. I was listening to him have a conversation with a group of governors, and he basically was saying to the governor of Maine, if you don't come into compliance with X, Y, and Z, you're not going to get. We know while we were up in Albany, Alicia and I were up in Albany about a couple of weekends ago, and the governor was, before that, just really stressing, because she was talking about hundreds of millions of dollars that that the federal government was probably going to withhold to the state for various things. So this level of resistance and organization has to happen at this level. And I know, a lot of us are tired and frustrated, but we can't afford to be tired. We can't afford to take a day off. We can't afford protest votes. We have to get involved. We have to make sure that our children understand, because I feel like a large reason why we are in this situation again is because we did not teach our kids, our nieces and our nephews, and the younger generation, and even our neighbors, about the struggle that we went through. A lesson unlearned is a lesson repeated. And so we've got a lot of work to do there.
Well, since you all are not holding back, let's talk about recent executive orders. A series of executive orders were issued that dismantled diversity, equity, and inclusion initiatives across federal agencies, including healthcare and research institutions. These orders mandated the termination of, quote, DEI offices, programs. They halted equity-related grants and contracts, eliminated references to race, gender, sexual orientation from public health agencies. Additionally, new definitions of sex and gender limit the recognition of transgender identities in healthcare policies. How do these policy changes impact the ability of healthcare providers and researchers to address health disparities, particularly in marginalized communities and dealing with Black and Brown patients? How do we counteract this?
I mean, again, I think the past is prologue. We're sitting up here. You're a Kappa. I'm an AKA. I see another AKA in the. We got. Oh, see, got. Here we go. So back in, I think it was the 1950s, 1950. We had some members of our organization that went to Mississippi and saw how horrible it was in Mississippi, right? And we went to Mississippi, my sorority. We got permission to set up a clinic in Mississippi to treat the migrant workers, the people who were the people who were tilling the land. And then we realized that they weren't coming to the mobile clinics because their bosses weren't letting them off of work. So we took the clinic to the people. So we've got to come up with creative ways to get around the things that are happening while we're still fighting to resist what is happening, what is actually happening. We have the resources. We just have to be strategic in how we deploy them. And so, we've got the economy, we've got the know-how, we've got the expertise, we've got the resources. We just got to pivot.
Absolutely. And I would add to that it is vitally important not to give up before we've even joined the fight. So all too easy for institutions and individuals alike to comply in advance. And unfortunately, we've seen a lot of institutions who have taken a page from these executive orders and, for instance, removed access to bathrooms for people based on identity already, going above and beyond what any of the executive orders entail, because they feel that's what's coming, or that's what's expected of them, or that's the way to defend their funding streams, right? We have to be very careful about that. The important thing to remember about executive orders is that for the most part, while they can enact significant change, particularly if you're talking about cutting off a funding stream, they do not have the same force of law as legislation. They are uniquely open to legal challenge for that reason. And as we speak, many of these executive orders are being challenged in court. It's far too early to tell which of these are actually going to stick and which, could prove to be fleeting and will be reversed over time. I expect many of them will be. And so that's why it's all the more important not to simply give up, throw in the towel, much less comply in advance, go above and beyond what any of these executive orders expect, because many of them may not be with us for long.
I just wanted to add something about thinking about this moment and in relation to Dr. Elke talking about the introduction of Medicaid in the particular year. 1965 is very important because we had other civil rights related acts that were passed during this period of time. And I think why, this is important to me because there was a certain understanding around equity. Like people should have access to, resources to live, like healthcare, housing. I think there was a particular understanding that this was a right and that this was important. And then it becomes codified in bills, laws, and acts and things like that. So it's a question if is that a common belief now? And I don't think so. I don't think our government, definitely, our current administration does not believe in that. I think they believe in transactions. So what can you do for me? Can you pay for your health care? You need to work harder. You need to work better. There's not a understanding or a belief, a universal belief around equity. So, I think that's what's going to make things a lot harder. And as far as we think about barriers to access to healthcare, is there a belief, particularly with this, what Congress passed last night, that everyone has a right to healthcare? And I don't think that's what's existing right now, or the common way that people believe about their community, their society, and stuff like that. And I think
Because I feel like right now they're operating in a bubble. They're in DC. They have to go home. And when they go home, they're going to meet the wrath of their constituents. And I think that's going to kind of have relate to a little bit of pushlash. Like we're in this like backlash moment. And the thing that I want to, kind of encourage people with is that everything that begins has an ending. Remember Hitler? We defeated Hitler, Mussolini, and all these other, Stalin. So there's a beginning and an end. And I think that we just got to hold out, push back, come together, pivot, figure out what we do in this moment, but know that everything that begins has an ending, and that we will have the opportunity. I believe, my faith teaches me that we will be victorious.
Thank you. I think that's a wonderful segue. Now, we talked a little bit about fear, right? We talked about how the current legislation or executive orders that are being passed are really creating this sense of fear, right? Fear amongst even hospital administrations, fear amongst other politicians, and fear amongst the community. And I want to think about the patients and their perspective and the fears that they and distrust that ends up developing because of what's going on even in politics. So the legacy of medical racism exemplified by events like the Tuskegee syphilis study continues to cause distrust among Black communities towards healthcare institutions. Studies have shown that Black patients often receive inadequate pain management. To this day, these are recent studies, delayed cardiac care, fewer life-saving interventions compared to their white counterparts. What strategies can healthcare institutions in Brooklyn employ to rebuild trust and to encourage engagement with Black patients and those who are from disenfranchised communities?
I'll speak a little to this. And this isn't so much for those of us who are in the room now, but for the audience watching in other places. I understand that we live in an environment where there is mistrust of medicine. And those of you who mistrust your physicians, your other providers, I would encourage you to think about our lived experience. I'm going to take you on a little journey, and I'm going to tell a love story. You may wonder, what in the heck does a love story have to do with what we're discussing today? And the love story that I'm going to share is the love story of my mother. It took place in Philadelphia, Pennsylvania. We won the Super Bowl this year, so I think that I can bring that up, and that's okay. So this love story crosses generations. So my mother was fortunate enough to meet an Army veteran. They got married, they started a family. They had 3 children, my 3 older siblings. She lost her husband as a young mother. And one day I was looking through family files and I looked at his death certificate, and prostate cancer was listed on his death certificate. So my mother's heart was broken once from prostate cancer. She recovered. She eventually began to date again. She met a charming man, my father. I like to refer to myself as the whoops that could still happen because I don't think that my mother was anticipating having another child. And I'm sure that my father didn't expect it either. I'm growing, they're raising me. I am a senior in high school. It's the beginning of my senior year of high school. My father was diagnosed with prostate cancer and dead within a year at the age of 15. So, for those out there who question and who mistrust your medical providers, I encourage you to get to know us and to think about our lived experience. I do this, I address prostate cancer in the community because I don't want other families to deal with the same suffering that mine did. There's a saying called windows, mirrors, and transparent doors. And it was actually glass doors. And it was actually created by this professor at the Ohio State University. And it was used to describe children's books, but I think is actually very relevant today in healthcare and also with the struggles that we're dealing with in DC. I think it's important when interacting with each other to think of ourselves as mirrors. We're all reflections of each other. We also serve as windows. It's up to us to sort of invite others in and to share our experience. And then those transparent glass doors and inviting others in, they allow us to sort of see our lived experience and also to develop empathy. And empathy is necessary, not just within Brooklyn, not just in New York State, but in our entire country. Because as you mentioned, there will be hell to pay when the lawmakers go back to their local communities and they see the impact of Medicare and Medicaid cuts. It's going to impact everyone. And I think that it would be helpful if we kind of all stepped out of our bubble, think about the love stories that happen every day all over. And I think that this can allow us to come together and realize that we have more in common than we realize.
Yeah, I'd just like to add, thank you so much, Brian, for sharing that and, and all the things that your mom went through and how you have come to a place where you're doing that in terms of being a urologist and addressing that. And I think what you said, the importance of it is going out into the community because sometimes we stand behind our desk. We, as researchers, we may be in our offices, we may, as clinicians, we may be in the hospital. And I know there are time constraints and so on, but in order to build trust, you need to step out and you need to go out into communities. People need to see you. People need to understand. Share the love stories there that need to be shared, and I think that helps to build trust once they understand where you're coming from and that you have their best interests at heart. If we are in our own bubbles, so to speak, we're not going to make much of a difference in building trust within the community.
And, they're not empty words. It's not cliche. Representation matters. We need more Black doctors. We need to continue to educate more Black doctors. That starts with the HBCUs, but continues on with institutions like Downstate. So we need to continue that mission.
And just to sort of piggyback off of that, I'm curious about your thoughts on how we train those doctors as well. I'm just trying to think about kind of like my own personal experiences. My father also has prostate cancer, and I remember going through doctor visits with him. And, sometimes the doctor really not understanding his perspective, understanding his lived experience. And, my doctor, he likes to brag. He's like, yeah, my son's the doctor, and so the doctor, often kind of like redirecting his energy towards me because he feels like he can relate to me better. And I'm like, well, but my father is here, And so is there something about how we are training the next generation of doctors in which we should focus on to help rectify situations like that?
So I'll speak a little to that. So when training the next generation of doctors, I think we often focus on students in medical school. But I would actually argue that we should look towards colleges. We should look towards high school. We should look towards elementary school to sort of encourage youth of all backgrounds to pursue careers in healthcare. Because we live in a nation, I think our population right now might be about 330 million or something like that. We live in a very diverse country. And diversity is a good thing because those who identify with the communities that they serve do a better job. And that we need to start planting those seeds in elementary school, in middle school, and high school. And I think that pipeline programs, namely some of the pipeline programs that exist here at Downstate, are incredibly valuable towards that goal.
Yeah, and we start out, thank you. Yeah, we start out with middle school. We used to have a high school, started out with high school from grades 10 to 12. And these were students that are interested in the health professions. They would come here. And the great thing about coming to Downstate and coming to this institution is that they were able to see other people, right? So they could see Teresa as a physician, you know, they could see Marcus as a researcher, and they're able to model those things. And had they not been at Downstate where you have all the different colleges and all the different schools, they would not have been able to see that. And so they come here and they get to do a host of clinical things. They get to work with faculty and so on. And that was 10 through 12. And we recognized that we needed to start earlier. So we went to ninth grade, and ninth grade students come here on Saturday. And we even thought, like, you know what, we need to go even further up the pipeline or the pathway, so to speak. And so we are going out to one middle school, and they have different curricula for different ages. So the sixth graders get general health sciences, the seventh graders get sports medicine, and the eighth graders get forensic sciences. Those are the NCIS people that really want to know about all the forensics. And so that helps in terms of like creating that pathway. And when we look at our alumni, 70% of them continue on to STEM. And we look at, and most of them, 90-something% of our students graduate in 4.3 years with their first degree compared to a national average of 6 years. So those things matter, starting earlier in the pipeline and not waiting until college, but really helping students to see what the possibilities are and making sure that they're part of that.
I just want to add to that. You know, I completely agree and have worked, you know, with all of you and trying to diversify the workforce starting from early STEM. But it's also important that we teach non-white physicians empathy and about our lived experience, just to show you healthcare disparities. My father, too, was diagnosed with prostate cancer, and he had a physician that was here at the VA, actually, but affiliated with Downstate, a faculty member at Downstate, and he received the most compassionate healthcare that I've seen of any physician, and he was white. And so I think it's important that not only we diversify the workforce, but that we teach our, you know, non-Black colleagues what the experience is, our experience, and how to interact with patients coming from our communities. It's extremely important to have empathetic, compassionate healthcare for all of the physicians, not just the Black ones who come up, but all of the physicians.
Yes.
Yeah, I mean, like I agree with everything that was said, and I, you know, just to piggyback off of what my Delta friend said, um, cultural competency I think is incredibly important, and not just Black and white, but like even within the Black community, we're not a monolith. You have, you know, Blacks who are from Africa, you have Blacks who are from, you know, America, you have Blacks who are from Caribbean islands. They're totally different lived experiences, and so cultural competency across the board I think is something that's very, very important.
And one of the ways I think that we build empathy is not only, you know, in sort of education modules that speak directly to empathy, but really giving doctors to be an opportunity to gain a sense of just what is ailing our healthcare system. I hesitate to call it a system, our healthcare environment in this country, indeed this region. And in my experience, students who really have a clear sense of kind of where they're situated within this mess develop as they go along much greater empathy toward patients as well.
I wanted I want to talk about a very academic term. Before I tell you what it is, I think you all will resonate with the fact that some clinical decision making historically has been made based on race, which we know is a social construct. And the term that I want to sort of dive into is this aspect of, it's called racial essentialism, this false idea that race is a fixed biological determinant of health. And it's long influenced medical practice, shaping how diseases are diagnosed and treated. This is reflected in the use of race-based clinical algorithms, which embed racial bias into decision-making tools. I often think about, there's a social media person who breaks a lot of this down. And for example, adjustments to kidney function, EGFR, risk assessments for heart disease, maternal health protocols, they all have historically included race as a factor, despite growing evidence that there are social and structural determinants, not necessarily genetics, that are driving health disparities. And similarly, statements like RFK Jr.'s claim that Black Americans should have a different vaccine schedule really, I think, fuel a lot of these misunderstandings around race and genetics. I'm looking forward to the panelists sort of explaining some of this. How does race-based clinical algorithms reinforce racial disparities? And what steps can be taken to eliminate racial essentialism from medical decision-making?
Well, I can start. I don't have an answer. But this is something I'm grappling with right now, working on a project with PIs here on precision psychiatry and using genetic data to help to, I guess, inform or diagnose psychiatric disorders or conditions, particularly depression and anxiety. And, you know, I was brought in because you have this genetic ancestral data, but to, you know, to be able to develop these algorithms, they're linking it to medical records or electronic health records, and who enters you know, data into the, or information into the electronic health records. They're humans, they're people, and, you know, all the ways that, you know, their own life experiences can influence diagnoses, how they might diagnose mental health condition, as well as information, so social demographic information like race, like gender, and things like that. So one thing that we are kind of grappling with right now is, can we capture the potential bias that might come from humans entering data into the electronic health records. And, you know, some things that I think about or bring into this is, even I am critical of categories around race and ways that they even reproduce ideas around, like, race being a essentialist notion, like racial categories that we fill out, you know, every day, and all the things that we do, and particularly within, you know, research and you know, hospitals, when you come into the hospital and the demographic data you fill out. So even thinking critically about that and how people's understanding of race might vary based off of places' history, based off the history and contemporary kind of social conditions that might be happening. Like, you know, they may look at someone and because of their particular understandings of the place, may say, okay, this person is this particular race or ethnicity. So I'm really, or we are really trying to think very, you know, specifically, because this study is across a number of different sites throughout the country. So, you know, I'm really thinking about the histories of race or migration to those places, and how that might influence how people understand race categories or racial identities and things like that. So I don't have an answer. And in fact, I was like, I don't like to use or think about race as determinative, or but, you know, it's something that I'm grappling with right now. I don't have an answer. But
Following off of that, I think that, you know, it is partly educative. So we have educative educative, I think that's the word. We need to be aware of what is going into the training in terms of the psychology of the way that physicians and other medical professionals are treating patients. But it's also about programmatic and policy steps. So not to sound like a Luddite or anything, but we need to treat with caution. I think the continued incorporation of AI and algorithms into treatment, knowing that it is very often a case of garbage in, garbage out. If racist assumptions are being fed into these machines, then guess what? They're going to come to racist conclusions. And so, you know, just knowing that and acting accordingly, I think could be at least part of the step toward a solution here.
That's great, thank you. So we will, given our time, we're gonna open it up to the audience to ask any questions. Please.
Hi, thank you for everything you've said. My three professors, I don't think will be surprised I'm the first one to put my hand up. So I'm thinking about how health equity affects so many people. And it's so important for the conditions and the lives of Black and Brown people. But the executive orders, the proposed cuts impact people who we don't think about when we think about equity. And again, my professors know that I think a lot about Black men's health. And there was recently a NPR story with a scholar who focuses on Black men's health. And it was just about, it's time to focus on men because men die younger. And the backlash was, no, men and blah, 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 you know, men have been the focus. And yes, however, they still die younger and we're not investigating that the way that we should. So when I'm thinking about health equity, even though I'm a Black woman and there's some resistance to broadening the tent, the folks who these legislators, Reverend Counsel, you said, are going home to, many of the ones who are going to be impacted are white, are poor, have a lot of the disadvantages that we think about in the Black community. So even though I'm thinking about my community and people who look like me, I'm also wondering how you guys think about broadening the tent so it doesn't feel like an us against them, so that the, you know, quote unquote, them understand that when we're fighting for health equity, we're fighting for them too.
Yeah. So if we're being honest from a historical perspective, the reason why Dr. Martin Luther King Jr. was killed was not because he was fighting for civil rights. It was because he started to organize poor people and sanitation workers. When he started to broaden the tent, the powers that be were like, absolutely not. Like because that is the through thread. And that is the thing that becomes very frustrating when you're looking at, like, across the board, the people who would vote against their own interests in the name of white supremacy. Is very disheartening. But I feel very strongly that 20,000 people being let go is indiscriminate. They're not looking at who it is that they're firing at the federal level. The impact of Medicaid and Social Security and the decisions that they're making and the fear and the panic that it is causing. So, you know, I strongly believe that they're just like, you know, like when you put a pot on the boil and the bubbles start to come up, that they start to burst. Again, like when they come home and they have to deal with those types of things, it is my sincere prayer that there will be a backlash in the midterm elections, that there will be, like, we'll have absolute recourse, because I think that what this administration is trying to do is to create a constitutional crisis. Yeah. And they've already framed the courts in a way that, because they want you to go up to the Supreme Court, that they framed to respond in a way that's given him immunity. So there's a lot of work that we have to do to make sure that our kids understand how these systems work. I believe that the solution to the issue is a deconstruction of all the systems. We got to tear it all down and start all over again. But we've got to do it from a pure lens and use our hearts and not those other things that come into factor when we're making those types of decisions. There's no easy way to do it, and there's no it's not going to be something that happens overnight, but I think we can get there.
Thank you, Denise, for your question. I would say that it's absolutely essential, following off points there, that, we broaden the tent, that we think creatively about building alliances. This has proven the path forward in terms of not only initiating new programs, but defending existing programs. So there's an unfortunate truism that we often hear in political circles, and it is that a poor person's program is a poor program. Now, what that means is not that it functions poorly, but that it probably has very weak levels of political support, because guess what? Politicians are listening to those with money, right? So the reason that Medicaid, to go back to Medicaid, was able to go from an afterthought to a very robust program, actually, that enjoys considerable support despite the dangers it faces today, is that, not only was it seen as a program that, yes, helped many poorer Americans, but many of those who were solidly in the middle classes also knew people who were on Medicaid. Guess who relied on Medicaid? And that proved to be the secret, really, to strengthening Medicaid as a program. So I think as we're thinking about ways to not only initiate new programs, but defend those that exist, we need to think very creatively of not thinking within small boxes, but expanding, thinking outside of the box in terms of the alliances that we can develop to support these programs.
I'll just add maybe another way to think about this too, think about Bell Hooks's work around, or thinking about centering the margins, not only her, but other Black feminists. Like if you develop a policy that centers poor people and access to healthcare, it's going to benefit a lot of people. Or if you center, have a baseline, this is what all people should deserve, then, then it should benefit a lot more people and stuff like that. So I think that the issue today is around the naming. Let me not say that's an issue, but I think that's what the reaction is to the naming. But where this program is for Black men, this program is for Black women. But I think there's ways to strategize, to develop programs that affect Black men, affect Black women in ways that you don't have to actually say, this is for Black men, this is for Black women. So I think that's a part of the strategizing. Centering the margins and strategizing ways that, there's a baseline that everyone should at least have this level of access, and then other people will benefit. Mhm.
Going back to what you said about the naming,
Mhm.
we know the reality is if we don't point out women need particular care, we're looking at mortality rates among Black women, we're looking at the white counterparts and how well they do versus Black women in terms of cancer care, et cetera. How do we get others to really understand that? Maybe we don't do the naming, but we really need to get people to focus on healthcare as an entity as opposed to breaking down the silos when we know as communities of color and as women and as men, gender specific, we need that particular identity in order to be able to say, hey, look at us. We need your support as well. How do we, it's probably a rhetorical question, I understand, but how do we get that needle to start moving in that direction?
I mean, I think one approach has been, place-based interventions, because we know there's a history of, neighborhood segregation. So, okay, if we believe in, I'm a drug use researcher, and I think about things like safe consumption sites or something like that. And if I say, okay, where should this be located? And if I know that there's disparities in drug overdoses among, Black men, I'm like, okay, the best place for this to be located is places. The safe consumption sites are located in Harlem and in Washington Heights. So you could go with a place-based approach. But yeah.
That's a hard question. It's a hard question because I think, sometimes the squeaky wheel is the one that gets the oil. So sometimes you have to, highlight and shine a light on the disparities. I think that's what happens here at I'm sorry, Downstate. Um, and I think that, sometimes it is important that you are like, hey, listen, this is happening in this community and something has to be done about it. But I also think that because it can be both and it doesn't have to be either or. That you can shine a light on the disparity and talk about what is happening in a particular community in order to get the resources, but you can still strategically frame the response in a way that it is not something that other people would see it as specific to one group of people. So, for instance, we were coming in, Lisa and I were coming in, and we were having a conversation about deed theft and foreclosures and how high those rates are in communities of color. But when we frame the conversation around trying to get resources, we're talking about distressed homeowners. And so we're not saying, oh, black and brown people are losing their homes at disproportionate rates. We know that that is happening. But as people are coming to us and talking to us about what is happening in Brownsville, in East New York, and in Bushwick, we're saying we need resources for distressed homeowners that are asset rich and cash poor. So it can be both and.
And I also think, favoring an approach that really appeals to people's sense of family and community, right? So even if a policy does not perhaps directly impact you yourself, you know someone, you have a mother, you have a father, you have, grandparents, you have cousins, you know people who are impacted. That's one of the ways actually during the 60s that support was built for Medicare, right? Those who'd been fighting for universal health care effectively decided they need to narrow their vision and point to a population that a lot of people knew to be deserving of assistance, right? Well, at that point, to turn 65 often meant to fall into abject poverty because you had to immediately pretty much spend out of pocket for any health concern. And so they appealed to people on the basis of that. Look, you have almost everyone knows an older family member, many of whom you may be supporting in some way. This is a program that will help them. Therefore, it helps you as well. So drawing on those connections too, I think, can be crucial.
Great. So I think we have one more question coming from the virtual world.
Yeah, this comes from the chat. G. Lisa, they say, no question, but wanted to express thanks. As a new FMP DMP student, the current climate can be scary, and this panel has me feeling more encouraged and motivated to do the necessary work.
Yeah, I think that's a great segue. Actually, we have one more question in the audience, and then we will wrap up.
Hi. I have a question and a comment. My comment is more toward the maternal rate and how mothers are losing their lives and infants are losing their lives during birth. I work with the maternal community, so that's very important to me. I just wanted to know what accountability would look like for those mothers and their physicians, because a lot of times mothers do come in and they express their concerns to their doctors and they're not being listened to. And I work with mostly the Black maternal community, and they express a lot of things to us to try to get their physicians to listen to them. And I don't feel like it should be that way. You guys spoke about how physicians and their patients should build a relationship with each other and they should get to know you guys. But I just feel like as physicians, you should dig into learning your patients more, listening to the patients more, because a mother can come in and she can say that she is not feeling well in her stomach or she was spotting, and the level of care that she gets for that is very minimal. And then the next thing you know, she's giving birth and something goes wrong. And it was something that she came into like the office before and was not addressed properly. And I feel like there should be accountability for that for the doctors and how they are building relationships with their patients. A patient comes into the office, especially a mother, should feel safe with her doctor and be able to tell her doctor anything and should not have to worry about her political view or her race. She should be addressed with the care and attentiveness that her physician cares about her. So I, for the community's sake, would like to know what accountability for that would look like.
That's a great question. I'm going to kick it off for the panel. Unfortunately, as we said before, when we're training physicians, whether they're Black, white, outside any race, We need to train them to be compassionate. But the fact of the matter is that not every physician working today is compassionate. But you have to hit them where their pockets are. And so connecting reimbursement to value care is where their pockets are. So whether they're compassionate and empathetic and should be doing the right thing anyway is what we hope for. But what we can count on is that if they don't produce proper quality metrics, they don't get reimbursed. And we need to be pushing for that. That's how we advocate. But I'll hand it off to Leah.
Oh, thank you so much for that question. And I think yes, training, as you know, Dr. Smith said, and people being compassionate and understanding that healthcare is such that you should be, right? And you shouldn't be in that position if you do not want to be compassionate or if you do not want to understand your community. So training goes into that. Also asking the community, how do they think? What do they think accountability should be? What do they think are the benchmarks of what I think a good doctor should be, a good clinician, a good nurse should be? Because oftentimes we have the benchmarks from the academic side or benchmarks from the clinical side with no input from the community in terms of like what they think should be good. Like how do this doctor, how does this nurse make me feel when I'm in their presence? Do I feel as though I'm listened to? Do I feel as though they're even looking at me or they're just, writing something else or on to another patient while I'm there? So all of those things should be part of the accountability and the benchmarks for which we measure accountability. And I agree that you hit people where their pockets are. That's a good way of doing it. But again, thinking of a strategy that's more community engaged with clinicians to decide on what accountability should look like, what are the benchmarks for a successful encounter, so to speak.
And I do want to, I don't know if I agree 100% with what you said about the money hitting them in their pocket. But I also want to kind of highlight that the borough president has made maternal mortality a bench, like one of the cornerstones of. He ran on this issue, and when he became the borough president, he gave $45 million, all of his capital money in his first year, to all 3 public hospitals to make sure that they had state-of-the-art neonatal units. He then put together a maternity mortality task force that is still meeting, and pushed for. Everybody was pushing for doulas, and I think doulas are great, but I think doulas are a quick fix. So the BP has been pushing for more midwives to work alongside the physicians, working with the mom, advocating. So I think there's a lot, even though the physicians bear a responsibility, the responsibility, I also think that, we've got to begin to teach each other how to advocate for ourselves. As we were talking about earlier, a lot of times people don't even know what to ask their doctors when they go in. When I was giving birth to my daughter at Interfaith Hospital, there was a 16-year-old girl who was, she was complaining. She was in labor, and she'd come in multiple times, and they sent her home multiple times. But her mother said to the doctors, she's not going anywhere, because she's not going to have this baby at my house, and she's not. And so we have to also create that community that educates and advocates at the same time. We got to build the plane while we're trying to fly it.
Thank you. Thank you. And that's a great segue. We're just going to ask Reverend Counsel if you could give some closing comments to close out our session.
Stony the road. We tried bitter, the chastening rod, felt in the days when hope unborn had the thing that I'm constantly sharing with people, we talk about diversity, equity, and inclusion. The motto for the United States, which is on our currency, is e pluribus unum, out of many, one. That's diversity. The 14th Amendment, which they are trying to attack, birthright citizenship at birth. It also stands for. It also covers equal protection under the law. That's equity. And our Pledge of Allegiance ends with the line, "One nation under God, with liberty and justice for all." That is inclusion. These things are written into our foundation, and as this country was created. So we've got to educate ourselves. We've got to push back, but we've got to realize and recognize, particularly people of color, we've been in worse situations. This too shall pass, and we've got to learn and move forward.
Thank you, everyone. I really appreciate. Thank you, everyone. On behalf of the Office of the President and the Office of Communications and Marketing, thank you for joining us for this event. Please keep an eye out for upcoming events. We're going to do something special for Women's History Month. And just as a special nod to Dr. McNeil, we're going to be looking at doing a men's forum. And I know that this young lady will be a part of this in some capacity. So that will be June. So please keep an eye out for other things that we're doing and continue to support us. I want to thank everyone on our panel. Thank you so much for joining us and making sure that we have a voice in this conversation. Thank you all.